Welcome, I'm Dr. Tim Clinton, president of the world's premier Christian counseling association, the American Association of Christian Counselors. We're so excited to bring to you a special free Counsel Talk webinar on clinical depression, evidence-based counseling treatment and strategies with noted clinical psychologist and educator, Dr. Gary Sibcy. This is an example of the many benefits, including webinars, that you receive as a member of the AACC. God is working in and through the AACC in a mighty way. We'd love to have you join us. Over 6,000 mental health and ministry experts participated in our Waymaker World Conference at the magnificent Orlando Marriott World Center in Orlando, Florida recently. To learn more about how you can become a first-year presidential member for only $69. That's a huge saving off the membership. Click on the button below at the bottom of the page. Let's go now to Dr. Gary Sibcy on clinical depression, evidence-based counseling treatment and strategies.
Hello and welcome. I'm Dr. Gary Sibcy, and we're talking today about treating depression and about evidence-based approaches for treating depression. And, what we want to do today is give you another package of tools that you may have in your overall toolbox that you can use for treating depression. There's a lot of different treatments for depression. There's cognitive therapies, there's interpersonal therapies, there's psychodynamic therapies, there's medications, there's transcranial magnetic stimulation. There's just a broad range of approaches, and many of them have evidence that support their effectiveness. And today we're going to talk about focusing on one treatment in particular called behavior activation, and when is a good time to use it. It's not an approach to treatment that sort of keeps you, drilled down on just one approach. You can add this to other approaches. It fits very well within a Christian worldview. Clients seem to like it. It's pretty straightforward and simple, but it also is very effective. And there's some interesting stories about how it came to be considered a standalone treatment. When Aaron Beck published a really famous book on cognitive therapy depression back in the late 70s, cognitive therapy for depression had this behavioral component that Aaron Beck started with, and then it would turn into the cognitive and the schema-focused therapies. And over time, some of the researchers wondered what would happen if some people just got behavior activation and we compared it to, just cognitive restructuring and compared it to the whole enchilada of cognitive therapy. And he found that the behavior activation treatment, when it went head-to-head with the other components of cognitive therapy, did just as well, or in some cases even better, because people tolerated it better. Just constantly targeting their negative thinking and challenging it and sort of getting into a lot of cognitive restructuring activities sometimes would put a lot of stress on the therapy relationship, whereas behavior activation kind of works around that. So what we're going to do today is talk about depression. Make sure that for some folks, you might just need a little bit of just a little bit of an update on let's get the diagnosis correct, and then kind of understanding depression and what leads to it, what kind of factors can cause depression, but also maintain it. So the causes of depression are sometimes different from what actually maintains it and keep it in place. And then we're going to talk about behavior activation and really try to drill down specifically on how to do it and give you some pretty good ideas about how to use it in your practice. Now, another important thing is we did a bigger training on depression, and it's available through AACC. That's a 12-hour training that goes into 4 or 5 different modules like behavior activation, but they target different clusters of symptoms in depression. So if that's something that you want to pursue, we'll give you some links on how to get that and try to use that in your practice if you're treating people who are depressed. One of the things that we know about depression as we start to look at these core symptoms is, you used to think that there were just, medication could treat it and that's all you really needed. And some of the largest outcome studies done on antidepressant treatments for depression have shown time and time again that antidepressants will get about 30% of people to remission if they, just go to their doctor and are prescribed an antidepressant. And at the end of a year, using everything they can as far as drug combinations, they typically can get a group of people who are depressed, about almost 70% of them, to remission. But you got to keep in mind that means 30% of people are still depressed. And of that 70%, about 70% of them relapse within a year. So even if they're taking their medication. So depression is still there. People sometimes feel better, but they're still struggling. And so we need more treatments, and a lot of them are counseling and psychological, and then they need to really be integrated with a person's religious beliefs, and we think that this approach does a nice job of doing that. So the core symptoms of depression is we let people know that depression, the core symptoms are emotional. So it's an emotional disorder, right? It involves sad mood and loss of pleasure. You need to have at least one of these symptoms every day, nearly the whole day, over a 2-week period of time at least. So somebody may come to see you who says they've been depressed, and it may have started 3 months ago, and what you often would do is try to get them to focus on the worst 2 weeks of that depression, and then ask them about their mood and what's it been like. When people say they're depressed, ask them what that's like. What's it feel like to you when you're depressed? Some people feel really sad, and with that they may feel hopeless or guilty or worthless, and we'll get into some of those cognitive symptoms. But sad mood is tied to those perceptions of oneself. Another important part of depression is anhedonia. Right, so which is a loss of pleasure. So they don't enjoy things. They don't get as much pleasure or enjoyment. They don't have as much interest in the things that they used to enjoy, and so they stop doing them. And that's going to be an important part of understanding depression. Right, so some people feel really down and worthless and guilty. Some people are stuck in grief. Some people have lost their interest in pleasure and stuff. So those are emotional symptoms. And then, of course, there's the somatic or the physical symptoms of depression, which are changes in appetite, okay, so, and changes in sleep. This changes some with age, just to say. The classic presentation is loss of appetite and loss of sleep. And this is especially the case for, middle-aged adult females. For college students and sometimes teenagers, you can have more of an irritable mood, but you have reversals in sleep and appetite where they eat more and sleep more. Very common in college students to go off to college and then get depressed and then sort of want to sleep all the time and just eat or binge eat and gain a lot of weight. The psychomotor changes, where people can get really agitated, where they look nervous and fidgety and they have a hard time sitting still. They may get up and pace around and they're sort of bouncing around, but they're agitated, versus psychomotor retardation, which is where people feel really worn down and slow. And this is something that you observe. So it's a little different than the loss of energy and fatigue. Psychomotor retardation, usually you'll see that in literally slowing down of their movements and of their speech. So asking people about these different areas when they're depressed is very important. So besides just asking them about is their mood down, or they lost pleasure and interest, asking really people who are truly depressed about the physical symptoms that they're experiencing, especially the changes in appetite, changes in energy level and sleep. These are really important, and it establishes some of your expertise, right? Because just talking to, in sort of a coffee cup discussion about somebody's depressed mood may not get to those kind of symptoms. And then there are the cognitive symptoms, which are decreased concentration, hard for people to focus when they're depressed. And part of that is because they get stuck in their head ruminating, and we're going to talk about that more later. These feelings of worthlessness and guilt, sort of loss of self-esteem, attached to this can be feelings of hopelessness and helplessness, and then thoughts of suicide and death. When people start to feel depressed, they start to feel hopeless, asking them about whether they've had thoughts about hurting themselves or wanting to die. You can normalize that symptom sometimes by saying to people, hey, look, when people are feeling this badly and, it doesn't look like anything is going to get better, it's not uncommon for them to have thoughts about wanting to hurt themselves. Is this something that you've experienced? That can be a nice way of sort of introducing the idea, sort of normalizing, taking away some of the shame that people may have about having these symptoms. So diagnostically, you need at least 5 of the 9 symptoms we just discussed. They need to be present. All these symptoms need to be present for at least 2 weeks. In the same 2 weeks, they're experienced every day, nearly the whole day. So this isn't like a couple times a week that you're feeling sad and down. This is every day, okay? And it must include depressed mood and/or anhedonia. Now, sometimes we see people who are tired and they're worn out and they have low energy and they can't concentrate, and people jump to the conclusion that this is depression. And there's even rating scales out there, a very popular rating scale for diagnosing depression today. If you go see your family doctor, they're likely to give it to you nowadays, called the PHQ-9, or the Patient Health Questionnaire. And the 9 means the 9 depressive symptoms. And it's very common for people in medical settings to score above the cutoff range on there. Like, if they're up above 9 or 10, that would suggest that they're depressed. But they don't endorse any mood symptoms. They don't endorse feeling sad or feeling anhedonia or loss of pleasure. So they're not actually depressed, but they have these other symptoms. So keep in mind, you can't have the depression unless you've got those symptoms. Now, in the DSM-5, they added a number of specifiers. So it goes beyond simply, is this a single episode of depression, and coding it as recurrent or in partial remission, full remission, or does it have psychotic features? There's other important specifiers, and this is useful. So, for example, one of the specifiers is with anxious distress. And it turns out about 60% of people who are depressed will also have a diagnosable anxiety disorder. But there's a lot of other folks who have a lot of anxiety, and it's a big problem for them, but it doesn't really take the form of some new disorder. So with the DSM-5, it allows you to give the diagnosis of depression and also take into account this anxious distress. Another thing is with mixed features. And this is useful because there's a certain subgroup of people who are depressed who will have some hypomanic kind of symptoms that may last for a couple hours or half a day, sometimes maybe a full day, where they feel really good and they feel kind of excited and on top of the world. They're not doing things that are destructive, though. They're just feeling really, really good, and their thoughts are racing, and they have a lot of energy, and then it goes away pretty quickly. And it's not enough to meet hypomania to get like bipolar II disorder, but it's important and it needs to take in consideration. So instead of giving them, a bipolar diagnosis, it allows you to use with mixed features, and if they truly are bipolar, it'll eventually show up, but it's nice to be able to label it without having to give that other diagnosis or call it bipolar disorder when it may not be. And another subtype would be with melancholic features. And this is where it's sort of a more severe subtype with really severe anhedonia, profound sadness and guilt, tends to be worse in the mornings, and a lot of times what's called a late phase sleep disturbance, where they wake up at about 4:35 in the morning, they still feel really tired, they feel really badly, but they can't go back to sleep. And then they kind of ruminate about this a lot. And this melancholic feature is an important one, and often is most likely to respond more favorably to adding medications into the equation. Okay, so with that, we've got some different phases of depression. We're just going to hit these quickly. It's not, you don't have to, study all the different possibilities of depression and their different diagnostic possibilities, but it's good to recognize it. That, first of all, there's just normal mood changes. And you see sort of these ups and downs in mood, these fluctuations. This isn't any kind of bipolar disorder. This is a person who has more of an emotionally reactive temperament. And it's not a disorder, it's a temperament, it's a personality. And that type of personality is prone to develop an emotional disorder like depression or one of the anxiety disorders, but in itself, it's not a disorder. So be aware of that. A typical major depressive episode, right? So you've got normal mood, and then a person drops into this depression, and the depression itself may last, 20 weeks, whether it's treated or not treated. Now, sometimes people can get, treatment, to pull up my pen here, but they may get treatment here, right? And then they start feeling better, right? And when they get here, right, they go off the medication or they stop treatment because they're feeling better. And what ends up happening is the depression, sort of will tank back down, right? Because they haven't actually gotten over it. It's kind of like if you, have a sinus infection and you take a medication, you're only taking half of your medication for that, for an antibiotic, and you start feeling better and you stop taking it, and then it comes back. It's not actually a recurrence of the sinus infection. It just never really went all the way away. And that can be the case for depression. So to get really into a state of remission with depression, one needs to go for a couple months without any depressive symptoms. So this would be a recurrent major depression where, again, you've got this period of time that may last 2 weeks, it may last 2 months, it may last a year, but a person comes out of the depression and there's a period of time of at least 2 months with no symptoms, and it may be 2 months, this may be 2 years, it may be 2 decades before they have another depressive episode. And that would be a recurrent depressive episode. Sometimes people may have 5 or 6 depressive episodes across their lifetime. Other people may have something like this, where they have a deep depressive episode, which would be here, okay, and it's just one depressive episode, but they never really come out of it, and it lasts for 2 years. So this would be a persistent depressive disorder. It's a single episode of a single depressive disorder. Some people never come out, as opposed to something here where they don't actually go into a full depression, right? They just drop down into this sort of depressed mood more days than not. Not every day, nearly the whole day, but it's depressed mood and a couple other symptoms of depression more days than not for at least 2 years. Okay, so that's pure dysthymia. In the DSM-4, it was referred to as dysthymia. Now this is a type of depression that actually starts early, right? This would be persistent depressive disorder with intermittent major depressive episodes on top of it, right? In the DSM-4, we refer to this as double depression because they've got this dysthymia here that starts early in life and then a number of recurrent major depressive episodes that come in on top of it. So that's sort of superimposed on the dysthymia. In the DSM-5, this is referred to as persistent depressive disorder with intermittent major depressive episodes and a current depressive episode. So if they come to see you right in here, right, that would be a current episode. And noting the early onset. So in childhood, typically meaning before 18, people who start depression then are very unique in terms of how they respond to antidepressant treatments and to therapies. And we've done a whole training on just how to treat them. There's only specific treatments that work for them, to be honest. And behavior activation, which we'll talk about today, has had some success, but it's not usually enough to get people to remission. So, but be aware of that type of depression. So all that said, we could spend a lot of time on how to diagnose depression and all its different subtypes, but most of us just run into depression. We know it when we see it, and you may not take all the time to sort of drill down and get exactly what all the specifiers are. I think what's most important when you're treating somebody with depression is to make sure that you rule out if they have bipolar disorder and that they've not had some previous manic episode that lasted for a week and really caused problems, may even landed them in the hospital. That's important to know. The treatments that we're talking about can work for the depressed side of bipolar disorder, but there's plenty of times where you definitely want to keep track of whether or not they may start to get better, but they're actually moving into a manic phase. So let's talk about a model for understanding depression. And in the longer training that we do on this, we spend more time with this model because there's different ways of developing treatment targets out of it, okay? But I want to just cover this, and we won't drill down as deeply on all the components, but enough to sort of help you make sense of depression, how it works, how it develops, what factors put you at risk, what factors maintain it, and how does our treatment fit into that. So we start with this line where the things above the line are the things that people are pretty easily aware of and are able to report on, and the things below the line are things that they may not be so aware of, and that we know from research and we know from theory, but the combination of two are going on. So the first thing is just early adversity does create risk for depression. People who've experienced multiple adverse events, childhood abuse, alcoholic parents, death of a parent in childhood. There's a measure out there called Adverse Childhood Event Scale. We have that available for folks or a connection to that if you ask for it. And if people have 4 of these adverse events in their life, it quadruples their chance of developing a depression in adulthood, actually chronic depression. It also raises your risk for things like heart disease and cancer and various other problems. But early adversity tends to interact with a person's genetics and biology as well as their neurodevelopment. So there's a lot of things that go on in early neurobiology and neurodevelopment that interact with genes and environment to influence sort of how our brain thinks, sort of our cognitive style. We call it neurocognitive skill deficits that are actually in place. They're risk factors for depression, but they aren't the same thing as depression. So in other words, sort of rigid patterns of thinking or patterns of rumination or patterns of worry that sort of set the stage for people under the right conditions to get depressed. And these same experiences can develop underlying schemas. There are neurocognitive schemas, early maladaptive schemas about yourself, right? Your core beliefs about yourself. We talked about attachment theory over the years. These are these core attachment beliefs, same thing, about yourself, about other people, about how you handle your emotions, about God. Now, all this stuff can lie dormant, and under the right kind of circumstances, okay, this is an important piece, of stressful life events can actually activate a depression, right? And there's different kinds of stressful life events you can see in your slides without us changing slides here on the screen. But role transitions, where people have changes in their lives, right? They may be good things, right? I mean, you may get married, you may have children, you may get a new job, you may move to a new city, one that you've always wanted to move to. These kind of things are really stressful, even though they're good things. And when you're under stress, that can activate these underlying patterns of thinking, these underlying core beliefs, and a depression can emerge. We see it a lot with college students. They come to college, they're really excited about being there, but the stress involved and all the adjustment that goes with it can activate a depression. Of course, there's negative role transitions. These things could be like breakups, breakup with a girlfriend or boyfriend, or a job demotion, we call status changes, right? So somebody may lose a position at work. They don't lose any income, but they lose status, they lose influence, they lose power, and these can activate this. Then there's relationship conflicts, another area where people are actively arguing and fighting or having conflict with their spouse or their friends or their employers, right? These relationship conflicts can sometimes be overt, where you're actively arguing and fighting and having conflict, or they can be covert, where people just sort of pull away from the relationship and try to just ignore the people, not talk to them. Some people move all the way across the country to kind of get away from them. So that's a role transition where you move, but it was activated because of relationship conflict. You decided, I'm out of here. I'm going to the other side of the country. I don't have to put up with these people. So those are two. A third is unresolved grief. And we reserve unresolved grief to people who have lost somebody to death. Or we sometimes talk about the grief of losing a job or retiring, or your kids going to school, or these kind of transitions where you grieve a loss of your identity. It's not the same thing as the grief of losing somebody, so we set that apart. And then the fourth area would be loneliness, where people get disconnected, right? It can be a result of the other three stressors, right? Role transitions, moves, relationship conflicts, and death can lead to situations where you're lonely, right? Or you feel, you got nobody to talk to. You're good at making friends. You're good at keeping friends, but you can't figure out how to enter into that new social network. See this a lot with people, for example, who go into retirement. Over the years, I've gotten a situation where I used to treat, and still do treat, a lot of children and families, but I treat a lot of seniors nowadays, a lot of people who have moved into the retirement phase of their life, and they're very excited about not having to go to work anymore, but in an interesting way, all their friends, all their identity, everybody they kind of knew and did things with, they were at work. And the ease in which they thought they would reconnect outside of work and find meaningful, enduring relationships didn't happen so easily. So that can itself trigger a loneliness. There's other people who have long-standing problems with loneliness, right? So they're not good at starting relationships or keeping relationships, and they're shy and withdrawn, introverted, and that's a bigger risk factor that once a depression starts, sometimes that can make it tougher when we start looking at overcoming its effects. So stressful life events activate these underlying patterns of negative thinking and these negative beliefs that you have about yourself, and this would activate what we call the cognitive triad. Now, this cognitive triad is classically cognitive therapy, where at the heart of this pattern of thinking is a negative bias about oneself, about others and the world, and about the future. Right? So when I talk to people about this, that they realize that once they get depressed, their brain now is searching for information that confirms that they stink, others stink, the future stinks, the past stunk, and the future will too. Right? That's the way the brain's working at that point in time. And it systematically ignores or downplays anything to the contrary. So this negative pattern, the cognitive triad, is important to recognize. And this is what we often see in the cognitive distortions that we see with people who are depressed. And this pattern of thinking interacts with brain chemistry, right, and brain structure. So the kinds of things going on here at the end in terms of the brain structure and the neurochemical processes. And specifically, we're going to talk about how there's changes in serotonin, which changes your mood, but also changes in dopamine and what we call the positive valence system, which is this ability to feel good. See, when you do things that you value, that are important to you, interestingly, your brain then rewards you. It rewards you with dopamine. Dopamine is what makes you feel good, right? Not high, not euphoric necessarily, but good. So when you do things and you feel good about it, there's a chemical response that's involved with that. Also, brain structure. One of the things that happens when you get depressed and you have chronically depressed mood, right? These disruptions in these positive and negative mood systems or valence systems is that it starts to break down the part of your brain that's involved with memory and concentration. And people have a hard time remembering specific things that's good about their life. So we could spend a whole day talking about the neurobiology of depression. But what we know is that this negative pattern of thinking influences the negative mood, right? How you feel, your energy, your motivation, right? Your sense of hope. And when those get turned off, right, then we get a shutdown in the behavioral system, right? When people get depressed, right, they lose their energy, their motivation, their pleasure, and it turns off their behavior, and they get into a pattern of shutdown. And we're going to look at this more closely as an important point of intervention. Right? So when people stop doing things that they need to do, they stop doing things that they value, they stop doing things that are important to them, right? A couple things happen. One is it creates more stressful life events, right? I mean, if you get depressed and you stop doing stuff around your house, your spouse is going to let you know about it. And then that's going to fit back into your idea that other people just don't understand you. They don't get it. You can't just pull yourself up by the bootstraps. Right? Or if you're not doing the things that you think you need to do, you're not doing the things that you enjoy, then you start to feel badly about yourself. So in a very important way, this behavioral shutdown becomes sort of the linchpin that keeps depression active. It's an important maintenance factor in depression. And so that's the reason that Aaron Beck was able to see many, many years ago that cognitive therapy of depression, the way to override these negative patterns of thinking, okay, and to also revise even some of these deeper patterns down here, was to help people begin to change behavior. Because in a lot of ways, see, your brain really cares about evidence, right? So if you try to pump yourself up with positive thoughts, or you want to read the Bible and try to really understand what it says about you, but you're not doing the things that you think you ought to be doing, and you're avoiding the things that you used to do. You're avoiding talking to people. You're avoiding going places and doing things that you used to find meaningful and that you valued deeply. If you're not doing those things, it won't register. So that's going to be an important piece for us to understanding how do we intervene. Sometimes, well, the best place to start is here at the behavioral level. I used to think that if you did behavioral therapy, you were kind of just skin deep. But the problem is that that view doesn't take into account how our behavior interacts with the way that we think and the way that we feel on a biological level. So here in the last 15 to 20 years, we started to make this integrative connection between behavior, cognition, and brain functioning. We don't just think of it as the brain affects the way you think and what you do, but what you do affects the way that you think. And it also affects your actual brain itself, the brain structure and brain chemistry. So in an interesting way, as we're going to try to help people see, is that there's a neurobiology to feeling meaning and purpose in your life. And we want people to see that. When people engage in behaviors that reflect their core values, their underlying values, then the brain rewards you with dopamine. It rewards you with chemicals that give you a sense of meaning and purpose. Now, one of the things that we see that's problematic, of course, is when people use things that aren't that are substitutes for this, right? So, for example, people who smoke a lot of marijuana. Well, the hard thing is that when you smoke marijuana, your brain rewards you with dopamine. So the problem is that normal behaviors that you used to engage in, whether it's going for a hike or going for a run or spending time with friends, you don't get as much out of that because, well, your brain is kind of saturated with dopamine and needs a really big boost to get back to the same level that it was when you were smoking weed. That's the reason a lot of times then people feel like they can't enjoy doing things with their friends or they can't enjoy an activity unless they're smoking weed. And the same kind of thing for video games. I mean, think about a video game where, you know, a person's in front of a video game and they're playing it for hours and hours in this goal-directed quest to, you know, take some enemy hill. And, you know, they're playing this game with all their buddies and they're getting huge bursts and infusions of dopamine. They feel like they've actually done something. Like, whew, man, I think I'm going to kick back and relax now that I've taken that hill. I spent all day doing it. As if they've actually done something. And the result is, in day-to-day life, you know, cleaning out your garage or cleaning your room or folding your clothes or studying for a test doesn't give you near as much of a dopamine surge as what you can get out of a video game. So I sometimes explain it to people. It's kind of like, you know, when you go on Halloween and you get all kinds of candy and you bring it home and you got all these sweets and you just sort of stuff your face with them. And then the next day your mom says, hey, I want you to eat this banana and apple for lunch. And you're like, oh my gosh, this is awful. Right? You can't appreciate the natural sugars that are there because of all the sort of processed sugar that you've eaten has oversaturated your taste buds, and it's going to be a while before you get anything out of those things. So those are important things to take in consideration, especially when you're trying to work with folks who may have some of these substitute behaviors for dopamine brain or dopamine infusion in their brains. So with that, let's pull our slides back in place. We'll talk about how we'll start treatment, and we'll just talk about this slide here before we take a break and take some of your questions. But as you can see, there's a bunch of target domains when treating depression, right? You've got the loss of energy, motivation, and pleasure. We call that the positive valence system. There's sad mood and anxiety and avoidance behavior, that's negative valence. There's rumination and worry, the cognitive processes. But there's also things like unresolved grief and self-esteem attacks, the low self-worth, the perfectionism, the hopelessness, and the interpersonal conflict and rejection sensitivity. These are all important target domains for folks who are depressed. And in our more extended treatment training, that's 12 hours, we talk about evidence-based, empirically supported treatments that address each of these target areas. Today we're going to just talk about a treatment that you can use that will target these three primarily, and hopefully give you some ideas and some skills for how to use them, how to set them up, how to learn more about them, but hopefully kind of get you moving in the right direction with that. And then if you want more, you can take a look at our more intense training and learn some additional skills. We got some role plays that we use in demonstrating the skills, and then also some links to additional sources of information and trainings that you can do. So we'll see you after the break in just a few minutes.
Well, I've been watching Dr. Sibcy tonight and with you, and I have really enjoyed listening to a lot of the insights that he has offered to us on the treating of depression. And before we go to the Q&A, I want to take a moment to offer an exclusive discount code to the viewers of this Counsel Talk webinar for a special course titled Clinical Depression, Evidence-Based Counseling, Treatment, and Strategies. This training has been led by Dr. Gary Sibcy, our presenter today, and Dr. Todd Vance. And they will provide you with an evidence-based approach for effectively treating and managing clients with clinical depression. Because you are watching this webinar, we want to offer this course to you for only $269, which is over $200 off the original price. If you would like to learn more about clinical depression, we encourage you to take advantage of this offer. To access this discount, use the coupon code CDEO5 or click the graphic below, and the discount will be automatically applied to your cart. If you have any questions, email us at questions@counseltalk.net. Well, again, I want to thank you for attending this webinar, and it's always a real treat, Gary, to have you with us. Gary, do you see a lot of clients who are struggling with depression, or how did you get keyed into really working at refining your counseling technique and counseling skills dealing with folks who are experiencing depression?
Well, as I started to practice more as a clinical psychologist in especially in a psychiatric practice where we have, like 12 psychiatrists so psychiatrists, realized that, the antidepressants would only get people so far, and a lot of people couldn't tolerate them. Or
yeah, say that again. You gave some interesting figures, like 30% and 70%.
Yeah, now that came from the STAR-D study. The STAR-D study is what's called the sequence treatment algorithm to remission. So what they were trying to do is see how many people they could actually get to remission. Okay, a lot of antidepressant studies are fixed dosed, so they only give you like 20 milligrams of Prozac, 12 weeks, and then they see how it did.
It.
So obviously, if you're not well, they're going to try to add more stuff. So there's what's known as an algorithm of how do you add more medications to this or change medications. And so what they did was they wanted to see in a very large sample how many people they could get to remission. So the target now is get them to remission over the course of a year. And they would come in and they would go through a phase of 12 weeks, and they would give them a dose of medication and push it really to its highest level.
Okay.
If the person got well, they went to remission, they came out of the study and continued the medicine. If they didn't, they went to the next phase and they made a change, an augmentation strategy. And same thing, after 12 weeks, if they were well, they came out, otherwise they went to the next phase. So a lot of interesting data came out of this, but basically they were able to get about 67% or about 70% of people to remission. Okay. Which sounds good, but again, you got 30% who still are depressed. Okay. And very importantly, they found that people who failed the first two treatments, right, that only about 6 or 7% went on to get to remission after that.
Yeah.
Okay, so there's a lot of people who have failed a couple antidepressant treatments, right? And they're not all the way well. And so anyway, even with the 70% of people they got to remission, 70% of them relapsed within a year.
Yeah, that's staggering.
It
so
really
that
is.
really says, okay, medication is good, but we got to have another skill set. We got to have another weapon when we come to really trying to help people with depression.
Right.
Gary, one of the questions we had, are you seeing any trends with people showing a specific core symptom of depression since COVID? For example, are people showing more somatic symptoms over cognitive or behavioral?
There's nothing that I have seen as far as sort of symptom presentation. Are they more likely to be sad or anhedonic? Or are they more cognitively sluggish? Or so I haven't seen that.
Okay.
But I have seen that people have struggled with feeling more lonely, right? Initially, they were kind of okay with this, but
Right.
now, you know, they really have gotten out of sort of a lot of the patterns of connectedness that they
Sure.
had. Especially for folks I see that really were plugged in to church groups, where they were able to meet with people and spend time and sort of share with them. And now that's just not happening as much. And so sometimes people have a hard time getting back into the mode of reaching out and reconnecting.
Okay. What would you, so as you look at COVID, and we're over a year into this now, what would you say from a clinical perspective you've seen more of or you are concerned about?
Well, I have, like I said, I've seen more people get isolated, lonely.
Okay.
I do see people who have developed increasing anxiety. So a lot of times, you know, depression has anxiety that goes with it.
Right.
There's more people that I've seen who've got sort of what we call illness anxiety, where they're worried about having some kind of illness, not necessarily just COVID, but I have seen more and more people who are worried that, you know, they may have cancer, or they may have, you know, some colitis, and so they,
okay.
you know, they're wanting to go see their doctor more, and they're using their, you know, physician more than maybe what they used to. So,
Okay.
Yeah.
So here's another question. I had a client recently state that she is bipolar and that she had been told that she is bipolar because her depression during childhood and adolescence had not been treated correctly with the proper medications. The questionnaire says, I'd never heard of this. How do you recommend that I handle this situation?
Well, that's a little bit challenging, right? I mean, there's a lot of things going on about bipolar disorder in childhood. The DSM-5 actually made a really radical change in adding a new diagnosis to the depressive disorders.
Okay.
So in the 90s, there was a set of researchers who started to talk about pediatric bipolar disorder, right? And what they did is they looked at people who were adults and they asked them, when you were a kid, were you like this, right? And what they were talking about is the bipolar child is the child who's irritable and grumpy and grouchy all the time, and then has these huge explosions, right? So they're really reactive. And so they wanted to call that pediatric bipolar disorder.
Okay.
And they began, and this led to a 500% increase in antipsychotic medication being administered to kids.
Wow.
Right? Now, the long set of research done by folks around the country start to question, is this really bipolar disorder? So they did this very, very large study with, you know, about 1,200 kids who were diagnosed with this pediatric bipolar disorder. And they followed them into adulthood. And they wanted to know, well, what percentage of these kids actually convert to full bipolar disorder in adulthood? And what they found is less than a dozen. So you got 1,000 kids, and only, you know, a handful actually converted to full bipolar disorder. So they really weren't bipolar kids. Most of them actually went on to be depressed as adults. So it's interesting that this person's, what they're saying,
Yeah.
because it seems a little, based on the way it's phrased, is that it may be off. That so in the DSM-5, they created a new diagnosis, right? So that people wouldn't call it pediatric bipolar disorder. It's called DMDD, which is disruptive mood dysregulation disorder. It's actually a depressive disorder, starts in childhood, and it includes all the irritability and temper tantrums and explosions. So it may not have been handled well in the sense that the kids who are like this are also kids who are more likely to experience abuse, right? Because they're really difficult children in the sense that they're often hyperactive, they got ODD symptoms, and they're really difficult to get along with. And they're more likely to experience adverse parenting experiences.
This phrase that you use, your brain rewards you. That's an interesting concept. And is that tied to this the integration of behavioral dimensions into the therapy for depression? Speak to that a little bit.
Yeah, I mean, and this is there's some very wonderful research now that's going on where we're able to view the brain in real time. So you're not just taking pictures of the brain, you're able to take the pictures of the brain when it's doing things, right? And so more and more, we're able to see, well, what parts of the brain are activated, for example, when you see a picture of a stranger versus a picture of your wife, or a picture of you with your family, or or a picture of you doing some activity that you really like doing. And when people engage in those activities, interestingly, the parts of the brain associated with reward and the dopamine system are activated, right? So it's not just sort of a theory that that's what's going on. Now we can actually see it happening in the brain. But when you get depressed, what happens is part of the genetic and biochemical markers for this is that your brain shuts that off. And so you no longer feel like, or you're no longer getting or anticipating getting that reward. And so you tell yourself, well, I don't want to do these things anymore.
Yeah.
And we'll understand that a little bit more in the next section, but that's part of what's going on.
Another point that you brought up that is referred to by one of our questions here is you have the line, that which is above the line and that which is below the line. And oftentimes, what you said was people get sabotaged by what's below the line. They're not aware of it. How can you help people, like if you are a pastor or someone who teaches, how can you help people to be more sensitized to paying attention to or discovering what is below the line before it really jumps up and bites them because of some life stressor or something?
Right. So, yeah, that's a great question. So for example, part of what we all do in our spiritual journey, if you will, is we try to understand our life. We try to understand what's happened to us. It's such an important part of understanding our testimony. And a testimony is this sort of narrative that you have about your life where you've reflected on it and you've tried to make sense of experiences. And so when you asked about how did I get into treating depression, I remember as a kid, I had a depressed mom. And I remember as a kid that she would call me into the kitchen and talk to me about her depression. And I would think, this isn't my job.
Oh, yeah, wow.
Right? Like
She wanted it to be your job, though. Huh?
Right. And I remember probably a very powerful period in my life is when I was able to say, I'm not doing that.
How old were you then?
I was probably about 11 or 12.
Wouldn't you say that's unusual? 'Cause
Yeah.
Wouldn't a lot of 11 or 12-year-olds get drawn into that? I got to fix this for my mom.
Oh, right. Yeah, no. And
You must have been an unusual kid.
I think I was. But sometimes it's looking back on the experiences, right? Because I can work with people who are depressed, and they get well. I mean, not everybody gets well, but if they're invested, they get well. But to be able to do it, I can't take them home with me in my head. I mean, I need to be able to walk out of the door and go home and play golf or play tennis or spend time with my family. I can't be obsessed with that, or I won't be useful.
Or your brain won't be rewarding
It
you.
will be rewarded. But part of that is, you know, we have to reflect on these experiences. I mean, early in my training, I would get kind of overwhelmed with this and try to understand, like, why am I doing what I'm doing? What attracted me to it? Yeah. So understanding your life story is one way to do that. And there's various points of time where we have people go back to make sense of what happened to you. And one of the things I do with folks anytime I interview people is I do a significant other history. And I ask, well, who are the 4 or 5 people who had the biggest influence on who you are today for good or ill? Mm-hmm. And I ask them some questions. What was it like to be around this person? How did you feel around them? Yeah. And then I would ask, what is the stamp that that person has left on who you are today? Mm-hmm. Now, that's a tough question to answer, right? Because you're like, well, wait a minute. And so it's a good way of sort of discovering the stamps that have been laid on your life.
Yeah, and I think that people who do counseling or therapy, people who minister to people from pulpits, etc., it's really important for them to do some of this work because they find themselves in situations that can be very challenging. And if they don't have a grip at some level of on what's below that line, it can become explosive for them and maybe even hurt a lot of people. So
yeah, absolutely.
We have had some Q&A here, and now we're going to go with Dr. Sibcy to the second session.
All right, welcome back. And as we were looking at what our treatment targets are, right, we're going to talk about a couple treatments, behavior activation and attention control training, which is a form of mindfulness, as ways of targeting these top 3 depressive targets or symptom domains. And I sometimes tell people if you target these 3, in a lot of ways, you'll address some of these other target problems down here as well. So we want to look at loss of energy, motivation, and pleasure. And, you know, the sad mood and the avoidance behavior in particular, okay? And anxiety and avoidance tend to go hand in hand, and we'll talk about that. And then rumination and worry. We'll get into that just a little bit more, but these are patterns of thinking. Rather than looking at just depressive content or anxiety content, right? We're looking at the way a person thinks. So rumination tends to be when our thinking gets stuck on the past, or when we tend to ask ourselves over and over and over again, why do I feel so badly? What's wrong with me? Why is this happening? Why do I feel this way? They get stuck in this pattern in their head. Whereas worry tends to be more future-oriented, right? What if this happens? What if that happens? Oh no, what if this happens? What if that happens? Worry, worry, worry. Okay, these are ways of thinking that are brain-based, and we want to help people learn how to break up out of that pattern. So now anhedonia is that loss of energy, motivation, and pleasure. And it's a disturbance really in what we call the appetitive pleasure reward system in the brain, right? And there's 3 components to this, okay? One is the anticipation, the sense of wanting to do something. When people are depressed, they'll often tell you, I just don't want to do anything anymore, right? Now, I don't want to do anything means that they don't anticipate that they'll get anything out of it. There's no sense of, yeah, I want to do that, right? And then there's the consumption component of that, okay, which is that once you do it, do you like it, right? So the ability to actually experience pleasure and enjoyment, or we sometimes call that hedonic impact of an event. Right, if you go for a walk, or if you spend some time with a friend, if you go play golf, or you play tennis or pickleball, or some activity that you enjoy doing, do you actually enjoy it when you do it? And then the learning side of that is that if you do enjoy it, then you start to think like, hey, I think I want to do that again. I sometimes say, like, in about November, December, I stopped playing golf because it's just too nasty outside. And I play a lot of golf, and I really anticipate it and like playing it. But come April, when I start thinking about playing again, I don't actually feel the anticipation to want to do it. I don't actually feel like, I don't even know if I want to play, right? Because I haven't played. And some of the reward mechanisms attached to it are not there. But I tend to know that if I go do it, I'll like it. And interestingly, when I'm out there and I hit a good shot or two, then I start liking it. I start enjoying it again. I can feel that sort of, right? And then I start thinking about when am I going to play again and start sort of planning how that's going to happen. So that's sort of the way it works in the normal day-to-day life. When people get depressed, usually it's the anticipation system that gets zapped, not so much the consumption or even the learning component. It's usually the anticipation piece, and that's going to be important. We call that mood-dependent behavior, because people end up just doing what they feel like doing, and if they don't feel like doing it, they don't do it. So the evidence-based treatment for addressing this is known as behavior activation. And basically there's 5 components to this. We're going to go through each one. One is we need to explain the depressive loop to our clients, right? And in a second we'll talk about why is that so important. And then we take some time to understand what are the core values that they have, right, before they were depressed, and that they still can identify, but also the behaviors that were linked to those core values. So if you believe something, if something's important to you, people got to see the connection to actual specific concrete behaviors. And then engagement in graded task assignments and behavioral scheduling, right, where we help them plan behaviors and schedule them. And for more complicated things, like cleaning a room or cleaning out a garage or cleaning out their car or cleaning a room in their house or doing their bills, we may break it down into smaller tasks. And then we practice savoring. Savoring is a way of enhancing your ability of liking and enjoying some behavior that you've engaged in. So, describing the behavioral loop, right? Now, the behavioral loop is sometimes the depressive loop. And why is this so important? In our clinical psych program at Liberty, one of the things we talk about very early in the program is about the therapeutic alliance. And there's 3 components to the therapeutic alliance. A lot of times people only learn about the one component, which is, does a person trust you, and do they kind of like you and think that you like them, and the unconditional positive regard. Well, that is important. That's only one component. The other 2 components are that you have a shared or agreed upon goals and agreed upon methods for accomplishing those goals. So obviously people want to get better. They don't want to feel depressed, but we need a more refined set of goals that we can agree on pursuing. And so when therapies use some psychoeducation to help people sort of understand why they're feeling what they're feeling, this does a lot of important things, and one of them is helps them see what we're trying to accomplish in the treatment. But it also sets the stage for how we go about trying to do it. And when we say that therapeutic alliance predicts treatment outcome, and it really does, it's more than just we can talk to each other. It's that they believe that the treatment makes sense and is going to work. And this accounts for a lot of why any therapy will work. People have to buy into its rationale. So I find that describing the behavioral loop and describing depression in this way is very easy, and people who are depressed, I've never really talked to somebody who's actually depressed who doesn't say that this really captures, in many ways, the essence of what they struggle with. So we start with the idea of stressful life events. Most depressions, especially first depressive episodes, are triggered by clear-cut stressful life events. Later depressive episodes are less likely to have as clear-cut a stressful life event, but they're always present. Usually there's subtle status changes, subtle relationship changes, role changes that affect a person's mood. Now, keep in mind that once a person's been depressed, right, once they've had a depressive episode, the brain remembers how to get there very quickly. That's the reason relapse is so common in depression. And we call that the kindling effect in the brain. So stressful life events activate or shut down energy, motivation, and pleasure. Now, sometimes I'll draw a little brain picture for a patient to see that it literally shuts down the chemicals that you need to feel a sense of energy, motivation, and pleasure. Now, the result is a depressive response. So what's a depressive response? That's when a person gets into an avoidance pattern of behavior. See, when you don't feel like doing things, then you stop doing it. If you don't think that you'll enjoy going for a walk or going for a run or lifting weights or spending time with your friends, or if you don't think that you'll enjoy it, then you tend to avoid doing it. And as we'll see, when you avoid doing it, that starts you into this loop, right? When you stay home, you don't do it, you get on the couch, you get in the chair, you isolate yourself inside, you disconnect. There you get stuck in these patterns of ruminating, right, about yourself. You feel sad, you may worry, right? You get into that pattern inside your head, right? And this gets you into a feedback loop, because the more you don't do, the less you want to do. And I explain it to clients like, when you stop doing the things that you value and that are important to you, okay, your brain says, hey, look, if you're not going to do things that that require energy or motivation or pleasure, then I'm not going to create the chemistry that you need for that. So the more you don't do, the less you want to do, and the less you want to do, the less you do. And so this creates the depressive loop. And it's a behavioral loop that is self-reinforcing. It feeds on itself. Okay? And so this creates, right, the rationale. Now I have it sort of explained out in a rationale here. Basically, is stressful life events, right? They trigger the depression, turns off the neurochemistry that support energy, motivation, pleasure, right? Leads to avoidance. You get cut off from your natural reinforcers, the things that are important to you. Now, important too is when you think, I'm not going to enjoy that, that's going to be no fun, that's going to be horrible, or I'm just going to feel worse if I do that. See, if you say those things to yourself and you don't do it, right, in a way, that's what we call escape conditioning. Because in your mind, at least, you think that you're escaping something that would be unpleasant or unenjoyable. And so that is reinforcing in the short term. So it reinforces that pattern of avoidance. But in the long term, it actually increases the depression. And as we noted, it also increases those stressful life events back here that we were talking about previously, right? Where when you stop doing the things that you need to do, right, that's going to create more stressful life events. So once people see this and they can buy into it, then we can talk to them about there's a way that we can help change your brain through helping you identify those behaviors that you enjoy, that you find satisfying, help you reconnect to relationships that are meaningful and important to you. So the first step is asking people what things they value. There's different ways that they go about doing this. One way is just say, let's think back to a time in your life when you were actually feeling your best, okay? See if you can anchor that down to a specific period of time in their life when they were really feeling good. And when they felt like they had all their, sort of all the pistons clicking and they were actually feeling good, you have to ask at that time, what did it look like? What were you doing on a day-to-day basis? What kind of things did you find enjoyable? What kind of things gave you a sense of satisfaction and accomplishment, right? Did you have friends? What kind of things did you do with your friends? What kind of things gave you a sense of meaning, right? We sometimes talk about the 3 R's. You need 3 things to feel happy, right? You need relationships, right? You need recreation, and you need work. Work has an R in it, but you kind of get the idea. That these 3 areas of your life, what kind of things, work gives you a sense of meaning and purpose and accomplishment, right? Recreation gives you a sense of enjoyment, a sense of pleasure, and you need relationships. Another way of putting this is that to feel happy, you need things to do, you need things to look forward to, and you need people to do things with. And in many ways, that sense of enjoyment, the sense of satisfaction and pleasure often overlaps with the people that you do those things with. So part of what we do, I'll jump up, is we do a life values interview. And there's different examples of this in the literature, of doing life values interviews with people and asking them, let's talk about relationships. What about relationships are important to you? Okay, and you know, let's think about family. With family, what kind of things are important to you? So somebody might go, well, I want to be a good mom, or I want to be a good dad, or I want to be a good son, right? Or I want to be a good grandson, or I want to be a good granddaughter, or I want to be a reliable, dependent family member. Okay, good. So then you take something, or take those sort of broad values like that, and you might say, okay, so being a good dad is important to you, and let's talk about what are like specific behaviors that you, if you were really accomplishing that value in your life, what would be like specific kinds of things you would do, right, that would reflect that? Now, when people get depressed, sometimes it's hard for them to get specific about these things. But it might be that you talk to your child or your son or daughter about their school or about their friends, or it might be that you show up for a baseball game, or it may be that you get on the floor and play checkers or play a game of cards, or you might watch a show with them, okay? And so that's an important thing, is to identify sort of really concrete behaviors. If you want to be a good husband or a good wife, what are concrete things that you might actually do that would reflect that value? Same thing with education, learning, career, right? Asking people, do you have an interest in sort of self-development in terms of what you know and you're learning? Sometimes there's a lot of people who are believers who at one time really enjoyed studying Scripture. They really enjoyed reading about theology, learning about God, and deepening their relationship, right? And that may move down to the mind-body spirituality piece of, again, identifying what were the activities that you engaged in that would reflect this, okay? Or in your career, what would that look like? You want to become a better therapist, you want to become a better engineer, you want to be a better employee. What are concrete things that would look like? And so you work through this with them in the recreation, interest, hobbies, right? What kind of things did you do that you enjoyed? And again, you can see how these stressful life events, so for example, a role change. One type of role change is where people have a health status change. Somebody, gets Parkinson's disease, or they develop, really bad arthritis or chronic pain, and a lot of the recreational activities and hobbies they did now, they can't do them unless they have pain, right? And up to this point, their definition of doing something fun didn't include pain in that, right? That's another important area to address. But these changes in what they used to like and what that says about them. What about mind, body, spirituality? I mean, do you feel like you would be taking care of your body? I mean, do you want to lose weight? Do you want to gain muscle? Do you want to work out? Did you work out? Is that something that you would want to be able to do? What would that look like? What about in the spirituality in your life in relationship with the Lord? How important is that? Let them describe that to you. At one point in time, it used to be very important. It was everything to me, but it doesn't matter to me at all now. Dig down on that. When you say it doesn't matter, you mean you don't have any motivation to do it. You sort of lost your sense of being connected to the Lord. When you did feel connected to the Lord, what was it that you were doing? What activities were you engaged in at those times? Sometimes people lose track of feeling close to God and the actual spiritual and spiritual disciplines that they may have engaged in at that time that helped to actually facilitate it, right? And daily responsibilities. When people get depressed, they stop doing things they need to do. They procrastinate. They put things off. They don't pay their bills. They, avoid returning emails and texts. And you got to help them identify what are the kind of daily activities you would engage in. What would a daily schedule actually look like for you? Trying to help them create some kind of order and predictability in their lives. So the life values is an important conversation. It may take a session or two to identify a range of behaviors in some of these areas, okay, that are concrete and specific. Now with that, then we begin to help people do some behavioral scheduling, right? Where you start to schedule at least 3 new behaviors to do each week. Now, a lot of times we ask people to engage in a behavior that may only take 15 minutes, right? Because basically you can do anything for 15 minutes, even if you don't have any motivation, even if you don't have any energy, you can still do things for 15 minutes. And then track how enjoyable was it? Yeah, what kind of sense of accomplishment did you get out of it? Did you feel connected? And remember, I mean, if you put on your list that, if somebody puts on their list that they want to clean out their dishwasher, right, then you might find that obviously you might not get any enjoyment out of it, but you might get a sense of accomplishment, right? How much enjoyment should you get out of doing the dishwasher, right? I mean, when you were feeling good, did you feel like that was amazing fun, or it's something that needed to be done and get done, and after you did it, you felt pretty good about it? So you want them to kind of be reasonable in terms of their expectations about what they'll get and then what they actually get, right? And there's different, in the full version of this, in the 12-hour version, we give you some worksheets that you can use with people to help them plan activities, break them down into smaller activities, and then really begin to predict whether they'll want to do it. I mean, whether if they do it or not, they get any sense of enjoyment, accomplishment, or connectedness out of it. Now, in some instances, we'll do some cognitive restructuring with folks, right? And in particular, we target the hopelessness, right? Now, sometimes it's important to target hopelessness when you're working on behavior activation directly, right? Because they feel like nothing's going to work, so why try? What's the point? What's the use? And in a sense, they kind of refuse to engage in the behavior activation process. And you want to be careful that you don't get into one of these sort of battles with people trying to get them to do things that they aren't willing to do, right? That's sort of a classic trap that you can get stuck into. So one of the methods that we spend more time in the 12-hour training on how to do this, but how do you target hopelessness with people? Well, one of the ways is by doing what we call motivation enhancement. And one of the methods for this is looking for what we call the logic behind the illogic. So in an interesting way, this is a cognitive therapy technique developed by David Burns, very powerful and a wonderful strategy. But it's really a psychodynamic therapy. And here's the difference between cognitive therapy and psychodynamic. So cognitive therapy is where you're trying to battle illogic with logic. Okay? You're trying to help a person examine really the logic of their beliefs. And sometimes that can be useful. A psychodynamic approach tries to find the logic in the illogic, right? And that's the reason I call it the LBI, the logic behind the illogic. And it basically says, well, you know, let's look at your hopelessness for a second, and let's talk about it in terms of, and let's just imagine that, you know, we had this magic button here on the table, and we pressed it, and all of a sudden, all your hopelessness went away. And in fact, you felt great. And, you know, you didn't even have any symptoms of depression. You were back to your old self and feeling good. Would you press the button? And most people would say, oh, yes, of course I would. Of course I would, right? And then you want to spend a little bit of time with them and help them understand, well, maybe there's some good reasons not to push that button, right? And this is a form of resistance that David Burns refers to as outcome resistance, right? And sometimes there's outcomes that people may need to face or have to deal with that they don't really want to have to deal with if you know, if their depression went away or if their hopelessness went away. So for example, what are some good reasons to remain hopeless? Sometimes people will tell you, why get your hopes up? Then you'll just get let down. Every time I've wanted things in my life and thought that my life was going well, then everything came crashing down. So it's easier just to not expect anything, not want anything, and just, you know, I don't like feeling miserable, but it's better than, and this is important, sometimes people literally endorse this, I don't like feeling miserable, but I'd rather feel miserable than to feel disappointed, which at that point, you got to accept that. And as a therapist, it's very powerful. Sometimes in the way to change hopelessness with patients is to see the logic in it or help them identify the logic. Another example might be, you know, a person who feels like if they start to feel happy, right, that's when bad things are going to happen. I sometimes refer to that as happy phobia, right? Every time something good's going on in my life, when I start to really feel optimistic, that's when the really bad stuff comes up. Some people have unresolved grief, right? And unresolved grief isn't just that you feel sad about somebody dying and that it hurts when you think about it. That's normal grief. Unresolved grief is that, in a way, a person has in their head literally convinced themselves that the person's not dead. And if they were to get back into their life and to feel hopeful and engaged again, it would kind of like be saying that the person really is dead and that you're moving on. And sometimes they're not willing to do that, right? That seems so disrespectful to the person I loved and cared about so much. Sometimes overcoming hopelessness may mean that they have to accept that they actually have physical pain, and they don't want to believe that they got physical, or have to accept that it may be here for good. May not be able to find a cure to their pain, their back pain, their neck pain, their arthritic pain. And, you know, if I start re-engaging my life again, I'm kind of saying that I accept this pain's here, and I don't really want to do that. So we spend more time with that. We don't want to get into the weeds too much, but that's a very powerful method to learn and to practice. And looking at some of the work of David Burns and his work can help you learn that skill a little bit more. Now, another thing that we work on right, is that when people engage in some of these behavioral experiments, right, so when they engage in, say, we come up with a list of things or a list of activities that they need to do and they want help with. When they do that, we want to help them do it in a way that focuses on the activity itself, right? So, for example, one patient of mine says that she wants to clean, she's been putting off the dishes and cleaning her kitchen. It's just really turned into a mess. But it just seems completely overwhelming, and so we kind of broke it down to sort of one step at a time, which came to, to clean out her sink, she had to first empty her dishwasher. So we sort of broke that down into steps, right? And then basically putting one dish at a time into the cabinet, and focused on how long she thought it would be, how long it would take. But very importantly, we want to work on attention control, right? So when people get depressed, their attention gets stuck inside their head where they worry, right, about the past or about past events or why they feel this way or why they're not motivated or why haven't they done this already? It's ridiculous that I haven't done this. And they get caught up in that judgmental thinking about themselves. Or they're thinking about something that may happen later, and they're worrying. So we want them to focus on attention control. We teach them the difference between focal attention, where you're deliberately focusing on just this one activity at a time. So we're going to get into that in just a second. So we describe the difference between rumination and worry. Sometimes it's useful to show people in the brain what's actually happening. So these slides help show where the default mode network plays a role in this kind of thinking pattern. But also, what can we do to help you break out of it? So the graded task assignment. This is where you take something like the dishwasher, you break it down, right, from something that's really big to something that's small. We break it into mini steps that are 1 to 5 minutes each, right? So you might do a 15-minute task, but you break it down into mini steps, each one maybe 1 to 5 minutes, right? So you open that dishwasher, you pull out that first thing, right? You put one dish away at a time, okay? You schedule sometimes 2 15-minute blocks to work on a series of steps. So maybe one is to clean out the dishwasher, and the other one is to load the dishwasher. Okay, you may do that later in the day. So we have them set a timer. Now, this is a very important technique. If you set the timer for 15 minutes and it starts working backwards, right? Or you can set a stopwatch that's working forward toward 15 minutes, right? So now after 15 minutes, you work as hard as you can for 15 minutes. You don't let yourself switch gears. You don't go do any other task besides the one you set out to do. And at the end of the 15 minutes, if you feel no increase in your motivation, right, then you can discontinue, right? Give yourself a reward like, hey, I did it. I made myself do something for 15 minutes when I didn't feel like doing it at all. And you continue, but if you feel motivated, and if that motivation comes and you feel pretty good, then you can continue, right? And if your energy and motivation increase, then you've learned something, and provide yourself some self-reinforcement. The one lady that I was telling you about recently who worked on this said that, I asked her how it went. She said, well, it went really well. And I asked her what she did. She said, well, I unloaded the dishwasher, but, I felt pretty good. And I went ahead and, loaded the dishwasher. And then I went ahead and, cleaned off the counter and I swept the floor. And then I said, well, heck, I might as well go ahead and mop the floor. And so she did really a bunch of activity once she actually got started. This led to a really great conversation about what we call mood-dependent behavior. See, one of the things that happens when people get depressed is that they tend to think in a bit of a distorted way that in the past, they've always felt motivated, right? And they tend to think that everybody else around them is motivated all the time, when in fact that's just not true, right? Most people don't wake up every morning and go, woo, yes, I cannot wait to get into that office today. You know what, I think I'm just gonna skip breakfast and everything and just rush right on in there. Most people aren't driving to work every day, you know, smiling, happy, can't wait to get there. No, I mean, most people wake up every day and kind of drag themselves out of bed, drag themselves into the shower, drag themselves into the kitchen, they pour a cup of coffee, they drive to work with a cup of coffee, but they know that after they get there and they kind of get into the day, then their mood will start to turn around. And they're not ruminating about why they don't feel motivated when they first wake up. But once you get depressed and you ruminate about this, and you think that there's something really wrong with you and you should be more motivated, and importantly, you wait to feel motivated before you start doing things. And that is the trap of depression. For depression to actually get its claws into somebody, they have to buy into that little packet of lies. That's sort of the final common pathway. If you don't engage in that kind of thinking and behavior, it's hard for it to get a real grip on you. Now, you might walk around with low self-esteem, and you might walk around feeling kind of bad about yourself and have negative thoughts about other people, and those are more amenable to cognitive restructuring, right, and schema-focused therapy that we can address with other interventions. But as far as breaking them out of the low energy motivation, no sense of pleasure, no connection, those can be broken up with these type of assignments. Now, one of the things that we work on is attention control training, okay? Basically, the idea is that when people engage in these activities, we want them to engage on practicing on keeping their mind on each step that they engage in. Now, these can be really small steps, whether it's unloading the dishwasher, whether it's, you know, cleaning your sink, whether it's, you know, engaging in some kind of physical behavior that's outside of your head, right? And that's sensory oriented. And when you engage in that behavior, right, your mind will begin to wander. It'll begin to go into the rumination or worry. And you want to grab your attention and bring it back, right? We want to block the wandering mind, because the wandering mind is what is responsible in most part of feeling depressed and anxious. And we work on this task in a lot of different ways. Sometimes I'll go over a really important study done by a Harvard group that included 30,000 people. And what they did is they gave these people an app, and throughout the day, they would send people text messages. And they would ask, how happy do you feel right now? How depressed do you feel right now? What were you just doing when you got the app? Did you want to be doing it? And very importantly, was your mind wandering while you were doing it? Now, after a lot of statistical analysis, this is what they came up with. How happy you felt at any moment in time was not very strongly related to what you were actually doing or whether you wanted to be doing it, but whether your mind was wandering while you did it. So what this means is this. You could be doing something that you want to do, but if your mind's wandering, you're probably not going to enjoy it, right? If you're thinking about, why am I not playing golf very well? I used to play a lot better, and this person's playing better, and that person's playing better, and nothing ever works out for me, and your mind's off the task, you're not going to enjoy it. But you could be doing something that you don't want to do, but your mind's focused on the activity and actually enjoy it okay, or at least feel content. So it's not so much what you do or whether you want to do it, but whether your mind is present, right? So we hear about this a lot, about the practicing of the present moment. And we tell people, when you do this, if you get the urge to do some other task, right, or you're reminded of another task to do, which is easy to do, like you're focusing on just doing your emails, and when you do that, you think of like 50 other things that you got to do. One of the things that you can do is just take a note card and write down, don't forget this, don't forget that, don't forget this, right, and then go back to the task. We have people practice in 15-minute time spans. We call this intentional, deliberate practice, right? So, you know, if you pick a task like cleaning off a table or folding clothes or washing dishes, straightening a room, right? Identify that task. Again, set your timer, right? You want to see how much you can get done in 15 minutes, right? And now, first of all, this becomes an experiment that we have people work on. Most people who are depressed actually greatly underestimate how much they can actually get done in 15 minutes. Procrastinators are really wonderful for this. Procrastinators go to work for 8, 10, 12 hours, but they only get about 30 minutes of actual work done because they're butterflying all over the place. So teaching them how to focus for 15 minutes with an identified specific task, this is what I'm working on, and see how much you can get done in 15 minutes, okay? And then when you do 15 minutes, put it down as a mark on a page. And the question is, how long, right, does it take you to actually do or to obtain 4 15-minute blocks of time, right? And we sometimes refer to this as what your efficiency rating is. Can you do an hour of work all at one time that's completely focused and goal-directed? I mean, if you can, by the way, you can accomplish a lot of stuff. And you imagine, very few people that I know can get more than 2 or 3 hours of actual focused, intentional, deliberate work in per day. But helping people build this capacity to increase their sense of efficiency and effectiveness can go a long way in helping break them out of depression, largely because they're getting things done, they're accomplishing things, and as Aaron Beck would say, this is new information, right? There's no more powerful data than the data that you get from behavioral experiments. They override these frozen negative beliefs that you have about yourself, about the world and other people. And so anyway, engaging in these activities provides a sense of self-efficacy and accomplishment and helps people realize that just because they don't feel motivated doesn't mean they can't get started, they can't accomplish things, and they can't get them done. There's more to practicing the combination of behavior activation and sort of the values assessment, behavioral scheduling, and graded task assignments, and then this attention control training that we embed within it, and we explain it more in the 12-hour training. But hopefully you can see how to use this, how to combine these methods for helping some of the folks that you're dealing with who are struggling with depression and a sense of worthlessness and a sense that life no longer has a sense of meaning and purpose. We can help them understand, well, how does this develop? But also, how can we break this pattern down? These methods are really useful, very effective, and I've just treated depressed people for years now. It's about 25 years, and literally in the office of, seeing clients for about 25,000 hours. And behavior activation is one of the treatments that I've found to be incredibly useful. I never thought it would be, but very effective tool package to have in my bigger toolbox. And hopefully you can find it useful in the work that you use with people who are depressed, and God will use it as a skill that you have to help accomplish His purposes and to sort of bring people back to feeling good, and then so that they can accomplish things to glorify Him. So hope this is helpful, and we'll take some questions from you here in the next few minutes.
Before we go to our final Q&A, I want to take a moment to offer an exclusive discount code to the viewers of this Counsel Talk webinar for a special course titled Clinical Depression, Evidence-Based Counseling Treatment and Strategies. This training is led by our guest tonight, Dr. Gary Sibcy, who is our presenter, and Dr. Todd Vance. And they will provide you with an evidence-based approach for effectively treating and managing clients with clinical depression. Because you're watching this webinar, we want to offer this course to you for only $269. This is over $200 off the original price. If you'd like to learn more about clinical depression and its treatment, we encourage you to take advantage of this offer. To access this discount, use the coupon code CDE05 or click the graphic below and the discount will be automatically applied to your cart. If you have any questions, email us at questions@counseltalk.net. Now back to our presenter, Dr. Gary Sibcy. Gary, thank you for taking time out of a busy schedule.
Thanks, Doc.
To spend
I
some
appreciate
time
that.
with us, and always enjoy getting together with you. And you always bless our AACC family. Let's jump right to a few questions because we're running out of time. How do you feel about generational depression? Are there any spiritual practices such as prayer that can help someone be healed from generational depression?
Well, I mean, there's a lot of ways in which you see generational depression, and some of it's genetic, some of it's learning, right? Some of it, you know, if you're raised with a depressed parent, the chances, even if you're not genetically related to that parent, so if you're adopted, I mean, it can influence whether you get depressed later.
Yeah, and it can be kind of like an intergenerational kind of component to that.
Yeah, absolutely.
Yeah, I think that's what this person might be referring to.
And prayer is a really powerful method that can be added into this, right? So when you're asking people, when you were closest to, or when you felt the best about your spiritual life and you were close to the Lord, what were some of the things that you actually did? And if prayer was a part of that, talking to them about, well, tell me a little bit about how you prayed. And what was different about the prayers that you had then and the prayers you have now? Or maybe once you started feeling bad, you started thinking that God had abandoned you or is not present. So, and at that point, if they want to talk about prayer and this is something you know, really would like to give them some ideas about, then they may begin to explore that as an activity that they engage in. You may say, well, why don't you try it, you know, for 2 minutes, right? And let's keep it simple.
Yeah, and prayer could be a great way of the therapist working with the person to discover and uncover some of the stuff below the line.
Absolutely. Yeah, prayer can be a really powerful catapult into sort of understanding some of these negative thoughts or feelings or assumptions that they may have had. So for example, a lot of times people kind of walk through life with this belief that because they're a believer, they're sort of in this bubble. I actually had this happen with a lady this week who's a strong believer, but her husband got COVID and died, and it happened in just like 8 or 9 days.
Wow.
Right? And now he had some comorbidities, but in her mind, God had really abandoned her.
Yeah.
Right? And part of it was, of course, we can't challenge any of this now, but this belief that, you know, I'm a believer.
Yeah.
And we have that sort of silent assumption that means that I'm kind of in this bubble and I'm protected.
Bad things can't happen to me or those I love. Yeah. You mentioned that earlier, you know, so much we want to avoid pain and the reality that bad things happen to good people.
Yeah.
Another question. How do you deal with a person who has an underlying medical condition like epilepsy as it pertains to the behavioral loop?
Well, same kind of thing, right? So most of the time they're being treated with, you know, for the epilepsy, so they're not having seizures and they're not engaging in activities that would trigger it. But we do see it also with things like very common with Parkinson's, right? You know, people who have MS, And so these are chronic, debilitating conditions, and they do really have an effect on their energy.
Yeah.
Right? And they really get tired more easily. And one of the things that we have people do sometimes to help them tease out what is this low energy that's related to my disease versus to depression, right? Here's a simple technique, is if you go for a walk and for 15 to 20 minutes, and at the end of that walk, you feel like somebody ran you over with the truck, that's disease.
Yeah.
Right?
Something.
If you go for a walk and after 15, 20 minutes, you feel at least as good as you did, but usually better, that's depression.
Yeah.
All right?
Yeah.
And I tell people, let's experiment. I mean, we got to figure it out. But many people who have the low energy and the pain and these kind of things actually think it's disease.
Yeah.
And there's no place in the medical record, there's no doctor saying, hey, don't go for walks, it's going to like zap you, that's terrible.
Right.
Like people who are like taking chemotherapy, you probably don't want them going for long walks.
Yeah. Yeah.
But most of them who have these sort of comorbid depression plus some physical disease, that's a good experiment. So 15, 20 minutes will let you know if this is disease. Like a lot of people I treat who have Parkinson's, they feel pretty worn out if they do very much physical activity. They like it, but it wears them
But
out.
it wears them out. Yeah, good point. Okay, if someone is able to go as long as 10 years between major depressive events, how do we determine that these are actually major depressive events instead of a normal downswing, possibly caused by SLEs? Is it necessary for the person to have a clinical diagnosis of depression years or decades earlier? I myself, this person says, have had periods of low ebb, but I wouldn't really call them depressive.
Really good point, right? And that's the reason that we do point out that there are normal ebbs and flows to people's lives. People experience stressful life events, they get down, they don't feel as much energy or motivation or pleasure, right? Again, within the DSM, the key is that you've got all 5 of these symptoms or more: sad mood, loss of pleasure, energy, motivation, appetite, sleep, every day, nearly the whole day.
Yeah.
And this is creating interference in your life.
Okay.
Right now, if you feel kind of down, several times a day, right, and your energy's not as good as it was, and, that it may not be a full depression. You're subsyndromal.
Yeah. Okay.
And these things work very well for helping people keep from getting into a deeper depression. But yeah, it's true. Not everybody who experiences these stressful life events, moves, transitions, losses, conflicts, they don't all get depressed.
Yeah.
But they may have changes in their mood, which is normal.
Yeah. Gary, as you were presenting, I was going back to Genesis. God created the human brain, the human body, hands, feet, eyes, ears, etc. And he assigned them a purpose. He said, I want you to multiply, replenish, subdue, and have dominion. And I was thinking about that and thinking, God has designed us to engage in work, purposes that we find value in. And when we do that, it's interesting to go back to your little mantra, the brain rewards us. And so this approach to therapy basically says, if we can find behaviors, if we can find tasks that this person believes to be significant, or if they can engage in purposeful work for a period of time, then the brain will reward them, because in a sense, that's the way God designed the brain and designed the human being to engage with valued, significant behavior.
Yeah.
And so
Absolutely.
not just to be thinking about it,
Yeah.
but to be paying attention to it. I love that book, Soul Anatomy, by Kurt Thompson, where he says we need to pay attention to what we're paying attention to.
That's
and
right.
so you've kind of combined those two things.
Yeah.
Do something for period of time, discover that you can, in fact, participate for a period of time in constructive behavior.
Yeah.
Then maybe even begin to assign some level of significance to the fulfillment of that. And what happens? The brain starts to reward that behavior, and you begin to come out of the depression and out of a sense of hopelessness.
Yeah, and you're literally, your mood and your energy come back online.
Yeah.
Two things that are relevant to this. One is working more and more with people who move into retirement, right? I mean, they get into retirement and they got this transition. They're like, I don't have to work anymore, okay? Which is wonderful, right? And they enjoy this for a while. But what they forget is that work creates this external mandate for you to get out of bed,
Yeah.
right? And that you have predefined things to do.
Yeah.
And people are, and we don't like that, but there's another part in which when you retire, then you run into the fact that you have to recreate yourself every day.
Yeah.
Right? Like, what am I going to do today? Well, that's great when you're on vacation for like a week and a half, right?
Yeah.
I mean, you've retired
Right.
recently, right?
Yeah,
It's
right,
important to have
right.
to be somewhere.
Yeah.
People are expecting you, and this creates this sense of mattering.
Right.
Right? I matter to the world around me, and we're made for this. We're
Yeah.
not really made to retire.
No, and I think we're made to say, I believe at our best, we're made to say, what can I do for Gary that will matter to him? What can I do for my wife, Peg, that will matter to her? What can I do for Tim that will matter to him? Because if I'm the right kind of person, at least at some level, it gives me great satisfaction to be doing something for others that matters to them. And then what I discover is, as I do that, I matter to myself.
Right.
Okay, and it's also important for me at times to do things that just matter to me, like play golf or go fishing or whatever.
Right. Those hobbies that you.
But you know, the self and others, and then I'd like to matter in my world.
Right.
That would be important too. But and I think sometimes I have to prioritize that and say, how do I matter in the world? If I have a high-powered job, I'm the president of the United States, I matter.
Right.
But what if I'm just a husband, a grandfather,
Right.
you know, a father?
I show up.
Yeah, you know, I show up and
Yeah.
I dig in and I do something.
Right. Yeah, I mean, how much does our presence and our attention matter to our kids and our grandkids, and that you know you're there and you're excited about what they're doing. That's very
You're
important.
retired and your granddaughter has a volleyball game and your first response is, I'm coming.
Yeah.
All right. So,
Yeah.
hey, thank you, Gary. Much
welcome.
appreciated.
Yeah, that
and
was a
I
lot of
know
fun.
you've enjoyed this webinar, and we designed them just to help you do a better job at doing what you do. So God bless you.